Thank you, everybody, for having me over here for this conference. I think it's a very, very special kind of a gathering, which you usually do not get to interact with at regular conferences. So I especially congratulate the APPI Organizing Committee and the host for bringing me over to meet such a vibrant group. Thank you. I don't think this is a strange situation for anybody here. I assume that most of us here in this hall are practicing pathologists. So we will move forward. I'm going to try and see if I can share some experiences and points of view based on what I myself have experienced through the past 3.5 decades. I'm sure some of you will be able to relate to those. Whatever I show you are from those kind of day-to-day experiences. Any laboratory, if most of us in this hall are working in our own labs or working in a lab owned by somebody else, whichever it may be, it usually caters to not a very large population unless it is a huge institution or hospital-based. I think it is pertinent to address in this gathering to people who cater to a smaller sample load. So I've chosen to talk about one of the most commonly sought after or asked for investigation, which is the routine hemogram or whatever you call it in your region, CBC, complete blood picture, whichever is the term. And most of us here use or are forced sometimes. Some of us have to be coaxed to use a cell counter as part of a laboratory. Some of us use it very happily, some of us willingly, some of us reluctantly, some of us think it is, a devil we have to live with. So I'm going to try and see, because I went through all these phases. That is why I'm able to say that to you. And I'll try and share what what has helped me along the way. CBC, is there a role for morphology in a standalone laboratory, especially focusing on the fact that most of us here are in standalone laboratories? See, firstly, why did we move on to automation? Why did we not stay with our traditional, conventional methods? Some of us were forced way back in 1980s to move from manual to automation a bit reluctantly. Why? Because it was an unknown ocean. We didn't know what automation meant at all. Definitely not in hematology. So some of us moved because we wanted to be a bit adventurous. Some of us moved because of these other reasons. One of the factors is that now, in the past 1 decade or even 2 decades, the general user, the end user of a laboratory has become very quality conscious. He is asking whether it is the physician who refers or not, the patient who comes and from whom you draw the blood sample himself has become quality conscious. And we are, whether we like it or not, we need to acknowledge the fact that the current day technologists are not the kind of technologists that trained us. Our technologists in our department used to train the postgraduates. I don't see that happening now. So there is a dearth of skilled, committed manpower in all laboratories. And of all areas, I think it affects hematology and histopathology a lot. So definitely we are affected by the lack of trained and skilled manpower. There is a rising sample load. Earlier, there used to be hospital-based testing, but now individual laboratories are testing for patients on whom we do not even know why we are doing the test. So the sample load has enormously increased. And this is the most common investigation that is asked for, whether you're serving an outpatient population or you are serving from a hospital-based laboratory, you still are doing the most commonly sought after test. So that's the reason why we had to move to automation from conventional methods. Having moved, what do we expect? We expect that automation should give us reproducible results. It should give us very precise results and like Dr. Sharavanan was trying to point out a factor, people want reports as soon as, you've drawn the blood, they're already waiting for the report. They tell you that if I go to the other lab, they give it at this time. So there is that, instant gratification has extended to this too. So immediate result or rapid results at least. Definitely everybody has become cost conscious. We also should be cost conscious. Those of us who run laboratories also need to be cost conscious. So we need to have methods that are cost effective. So we choose our instrumentation, our methodology, whatever we choose in our laboratory, definitely has this component in its decision making. We need to look at that. And very important, maybe we bought an instrument, maybe the reagents are quite easily available, maybe they are not very expensive too, but if your instrument servicing is not attended to when you need it, definitely you are not going to back that kind of instrumentation. You need a backup not only of your instrument but also for the servicing. We are trying increasingly to minimize human intervention because of several factors involving manpower. So these are the expectations that we have from the laboratory when we have automated cell counting. The traditional methods had several steps to generate one report that we all now sign out. If you had to sign out one sheet, it had multiple values, and each of them had a different method, different requirement, different skill. So you had to do hemoglobin, you had to do PCV, you had to do WBC count, you had to make a smear, you had to stain a smear, you had to do microscopy, you have to have a good newborn chamber, which is dependable, and somebody who is good at counting in newborn chamber to generate that one report. And it actually meant a series of tests. If you look at it, that one sheet that you sign on is actually not one report. It's actually a bunch of tests you are validating. So you can imagine how fraught it is with, how easy it is to make mistakes with using this kind of method. So obviously, automation is part of our day-to-day life, integrated into our day-to-day practice. Now we cannot do without it. It is almost like you say buy and get your washing machine, right? So it's like that. You just need to have it now. There is no go. So a series of investigations performed on one click, actually. So the cell counter now shows us a huge amount of data, a lot of information, all in one go, and all of it is done. So no wonder we moved from manual to automation. And now we need to see how we make the best use of this really a wonderful tool that we are all now blessed with. So we need to understand what the cell counter tells us. We need to understand its language. We need to understand when it is alerting us. We need to know what really works well with it and where we need to intervene. It doesn't mean that now the machine is there and we can sit back. I'm going to try and show you examples where your presence is what will make a difference to the CBC. So this is how the screen will look once the sample is run in a cell counter. I will not go into the details of this. So that's what the machine that has been, it's inbuilt with all that you ever wished for is there sitting on the lab bench and it's doing everything. But you had to really train and work hard to get to a stage where you could differentiate. When you were not so trained in microscopy, okay, let me say this. I think most of us are trained most intensively in morphology, right? Most of us. Most of us, in fact, pride ourselves in being morphologists. That is our forte. That is our strength. It still continues to be because our training is so deeply rooted in morphology. You're from day one to your exam date, all that you're asked is, okay, describe. So actually, we would be great poets, great authors, we would be. If one of us decided, I'm sure we'll make our language description, we could probably compete with Eliot on that. So when you joined though, I'm sure, I couldn't make out that, this field was very different from this field. To an untrained eye, there isn't much of a difference. But as you train, as somebody puts effort and trains you, you start to learn and you start to build a virtual visual library. Each one of us has such a rich library in our visual cortex. I think they should be analyzed. And so much data will come. Look at this and look at this. If for an untrained eye, they won't be very different. But to a trained eye, I would say, please go ahead and do a serum ferritin and confirm. To this, I would say, please do a HPLC. So, once you train, you pick up something so crucial, so intrinsically different. Are these not visible? Okay, I can't do anything. I don't know what to do. I'm sorry. I have a lot of images though. Okay, to an untrained, that's a trained eye that picked up. To an eye that is trained even further and pays a little bit more attention, there is almost a diagnosis in this. You would say, please do this test. What would you ask for? But osmotic fragility is only going to tell you that these are, yes, spherocytes. It's not going to tell you the diagnosis. What would you ask for? To really differentiate. You agree that there are spherocytes, right? We picked up the spherocytes. So what will osmotic fragility do? It will just confirm that there are spherocytes. But what we want to know is not just that there are spherocytes. We've already seen them. We should ask for a Coombs test. So you already have skipped so many steps in the analysis and gone on to identifying what would help in arriving at a diagnosis. And if you saw this kind of smear, this picture, what would you ask for? I'm sorry I'm making you stand, but there is a very interesting diagnosis here if you can pick up. Each of these cells, it's a very classic picture. Do you think it's a poorly stained smear? Do you think there is, it could be, maybe the smear didn't get air dried properly but if I told you, that is not so. You heard Dr. Manchanda tell you how to make out between a badly stained smear. You look at the other cells, they're looking quite good. So it's not a poorly stained smear. So these are not artifacts. Do you agree that these red cells are not normal? Okay, so it's a classic picture. Now can you tell me what you would do? G6PD. These are the classic moth-eaten cells. So if you saw this, you don't need to. You can just pick up the phone and talk to the physician. And even if he has not given you the diagnosis, the clinical picture, you can ask him, is this a child, a boy? Has he been treated for fever? Has he been treated for malaria? And you would get a classical history. So a good trained eye, morphology is your strength. Do not ever forget that. There are a lot of things that you can do that the machine is not yet able to do. Okay, to a discerning eye, to that knowing eye, we could pick up that. To a discerning eye, you picked up these, right? You picked up these, right? So sickle cells. To a discerning eye, the same diagnosis lies in this field too. These are the cells. They're called strap cells or whatever, but these just pre-sickling. So if you're screening a smear and you pick up such cells, you could just put up a sickle preparation. Doesn't cost you a dime, literally, and doesn't cost you any effort. It doesn't cost you anything at all to pick up a sickle cell disorder. In fact, you should just tell yourself that doesn't matter. Every time you suspect that there could be a sickle, you could put up a sickle cell preparation. And that's how you could increase your own index of suspicion by learning to confirm which of the cells you thought they could be sickle and turned out to be not sickle, and which you thought may be sickle and actually turned out to be sickle. That's how you can improve your own diagnostic acumen. You don't need a teacher, you don't need anybody next to you. You don't even need Google. You can do it yourself. Okay. Now, in this kind of, if you go to a cell counter and it tells you that there is microcytosis, it may still not be able to tell you the presence of this one occasional cell, which is a very important clue to the fact that there must be something underlying going on in the marrow if it is an adult. Maybe there is something infiltrating the marrow and pushing these cells out. If it is a child with a splenomegaly, maybe there is a cause for very, very rapid erythropoiesis, which means there must be hemolysis, right? So this cell would be missed by a regular 3-part cell counter. And look at this polychromatophil, these occasional macrocytes. These are not really picked up by a cell counter. So you, behind the microscope, will be the master, not the machine. Look at this cell. A single cell here. Look at this cell. This is a smear from a neonate showing even one such cell. I'm sure Dr. Manchanda will agree with me. One cell like this, a neonate. This is an immature granulocyte. It is almost like a myelocyte. It is showing a lot of granules and it's not yet, nucleus is not yet lobulated. Sepsis. This could be a clue to an underlying disease. So looking at the morphology is very rewarding. Okay, this is a perfect, nicely given histogram. You can see, I don't think you can read it, don't even attempt, but look at the values that this printout has shown. 13.6 grams hemoglobin, MCV is 116. Okay, so this is macrocytosis. So if you hadn't looked at the smear, you may have not even paid attention or you may have tried to explain it. But if you make a smear and you look at it, you will understand that along with this macrocytosis, there is actually something else that corroborates so well with what we all know, right? So why is it so? It's because this patient has been transfused. That's why the hemoglobin is normal. This is a post-transfusion sample, which the clinician will never tell you. You need to, so when you pick up something whenever there is a discrepancy, rule of the thumb, whenever people don't agree, it means there is scope to negotiate and get to the truth. If people don't agree, that means there is something, it is neither gray, neither black nor white. There is something in between. And unless you go look for it, you won't find that shade of gray. This also, when there is a discrepancy, you must go beyond what is given to you. You'll find that it's because a patient has already been transfused. So history again is important, and your morphology. Because of your morphology, you picked up that and your report doesn't look so awkward. 13.6, 116 MCV. It looks very funny, right? So you won't sign out that report if you had looked at the smear. You would put a clause saying that check for history of transfusion and also evaluate for megaloblastosis. Yeah, this I think maybe, yeah. Now, this is a 5-part. I've just moved from 3-part differential counter to a 5-part differential counter, which is showing you readings which are so, this is the scattergram on this. It's so bleak, it's completely odd. And the explanation is there on the smear. It's because of these large agglutinates, right? Well, I do not yet trust, although I keep reading papers and I keep looking at posters in conferences that say MP can be detected by the cell counter. I don't know if it would pick up this. I picked it up on a, at a low magnification, and sure enough, it is a vivax malaria. and we could make a diagnosis. I don't know if my cell counter would have done it. My 5-part too. And definitely it is, I wouldn't trust for it to differentiate between this, and this. I'm sure you can't make out this at the back, but there are 2 ring forms inside one red cell here, a normal sized red cell. So this kind of a diagnosis, this kind of identification that comes from your capability is going to make a huge impact in the patient management. These are not treated the same way. Vivax and falciparum are not treated the same way. Not only that, a sample in which these are seen is not treated the same way as a sample in which these ring forms are seen, because the parasite index in this individual will be much higher than this. So the entire clinical prognosis, the clinical management will be different. Now, can your cell counter tell you the difference between these kind of abnormal red cells and these kind? Now, who can tell me what these are and what these are? Anybody? Anybody who gets up should offer to also tell. This one is acanthocytes. This one is also acanthocytes. Bird cells. Bird cells? Are they bird cells? Bite cells? No. Bite cells should have, the red cell outline will be intact and a little bit of will be missing. Yes, somebody said that. Schistocytes. Don't use very complicated terms. Just say fragmented red cells. So easy. These, because that's what they are. They literally are fragments of red cell. So easy, once you say, use the term fragmented red cell, immediately all those clouds in your cortex, they move away. And you know what you are looking for, what you're looking at. So your instrument, I don't think, is going to pick up the difference between these and this, although it may flag. Unless you look at the microscope, you will miss these kind of diagnoses. So beyond looking at histogram, when you look at individual cells, you can point at in which direction the patient should be evaluated. You see this cell, one cell like this with a leukopenia, 500 is the WBC count, and this could be, at least it raises the antennae for what? What will you look for in this? Where is the problem? Red cells? Or this cell? It's marked leukopenia, but this, when you look at the smear, you pick up these blasts, possibly a blast, maybe a promyelocyte, maybe you can't tell, that's okay. But you definitely picked up that there is something underlying in the marrow. This one was an AML, presenting with pancytopenia, with such a low WBC count. But if we had missed looking at the smear carefully, we would have not picked up the diagnosis. Another leukopenia, and this cell, again, I'm afraid maybe the people at the back will miss, but this shows fine projections. Leukopenia, thrombocytopenia, and cells which are, this is an agranulocyte, this is a lymphoid cell with hairy projections. So another classical finding, which will be missed if you depend only on your 3-part or 5-part differential counter. And look at the range of these are from the same smear. This is a normal lymphocyte, and range of lymphocyte morphology like this. If you see frequent lymphoid cells, some looking blastoid, some looking monocytoid, some looking plasmacytoid, it probably is a viral infection, virocytes or transformed lymphocytes. Just leukocytosis, so we saw some examples of diagnostic morphology with leukopenia. Now, how about leukocytosis? All leukocytosis is not the same, and definitely we understand here it's simpler than leukopenia, that looking at the smear makes all the difference to know which type of what is the component that is leading to leukocytosis. This one is blast, this one is blast, these are lymphoid cells. So the line of thinking, diagnostic approach is different. This one is leukocytosis with these, what are these cells? Classical cells. I just kept some to remind us of our, like we had a UG biochemistry class, we can go back to some nice UG pathology class. This is a classical cell. It has a name too, Faggot cells. So leukocytosis with these kind of cells, diagnostic for APML. And a diagnosis that should never ever be missed. There are some diagnoses that irrespective of at what level of laboratory we are practicing, we should just not miss at all. We must train our eyes. One is malaria, especially falciparum malaria. You can save a patient from death. Otherwise, you can definitely save the patient from a lot of unnecessary investigation. You would have seen, I personally have seen many patients having LP done, CT scan, MRI, and it's a falciparum malaria. I've in fact even looked at a spleen with falciparum malaria. I don't want to remember that case. We shouldn't have to do that. If these are picked up, then the clinician wouldn't be doing what they did. So the onus is on us to pick up falciparum malaria. Every malaria, but Vivax may slip up between your fingers, so okay. But falciparum, no, never miss. Once you've picked up a falciparum, please report on the parasite load. Very important for the clinical prognosis. And when you've picked up another diagnosis like that, coming to this is APML. If you've seen promyelocytes, just keep seeing as many promyelocytes as you can. Now you have access to Google Images. Look at the variety of abnormal promyelocytes that can be seen, and don't miss it, because APML is a good leukemia. It's a leukemia that can be cured. So we shouldn't come between a patient and his cure. So we should pick it up as soon as we can. So becoming familiar with these images is very important. Yeah, this is also leukocytosis, but then this is a classical field for what? If you saw this field, CML. Yeah, this is leukocytosis, but a CML kind of picture. This is leukocytosis. This is from a patient with hypereosinophilia. So if your instrument is not sensitive to these, you will miss these diagnoses. And this is a morphology. Can anybody interpret this cell? Okay, there's a clue. There's a lot of these in the background. No, please look at this cell. The focus is not on that. The role is because this field is I'm showing you this cell, and this cell is in an area where the red cells are crowded. So this is not really. Look at this cell. What is the size of the cell? It's larger than any leukocyte that you've seen. And look at the surface. What's coming out of the surface cytoplasm? Megakaryocyte. This is a circulating megakaryocyte. And see what the number of platelets in this field. There is thrombocytosis. There is a cell which is probably a megakaryocyte. So if there is thrombocytosis and this kind of cell, please do not sign it out as thrombocythemia or whatever, but definitely you would ask for evaluation and look at the clinical history carefully to look for a myeloproliferative neoplasm. Okay, we will not. Okay, platelets. Yeah, the instrument has shown a high MPV, but look at the difference between a large, this is lost for the last benchers. There is a platelet here which is almost the size of the red cells that are surrounding it. So this kind of a large platelet can be seen with thrombocytopenia very typically in ITP. Now here you have a case of thrombocytopenia, and look at these platelets. and look at the other cells that are going with it. Always don't look at one cell line. Look at all of them together, because all of them together come from the same source, which is the marrow. So you have platelets here, which are really large, almost the size of the accompanying red cells. They're rounded. And then you have a neutrophil, or I don't know what, it's dyspoetic. So there are giant platelets, and there is a monocyte. So there is actually, if the clinician didn't give you the history, you could ask and you would find that it would be an elderly individual with dyspoetic platelets, dyspoetic granulocyte, and a monocyte. So what are we trying? So we should think of these things. Okay? These are all things that we can look at the peripheral smear and suspect. Everything you don't have to sign out, but you can, this is how you will be able to pick up more and more. So back to whichever it is, unless we are, we keep pulling out these visual catalog cards from our visual cortex, recalling what we have seen earlier, in what context we have seen, we do not improve our diagnostic ability. So we must not give it up. We are trained very well to be morphologists. We should continue to use that ability that we have honed. Along with that, remember that your morphology depends on how well you have taken care of these steps prior to that. So unless your smear is well made, unless it is properly fixed, unless it is properly stained, unless it has been collected properly, your diagnostic acumen is all not true. So, so you become a consultant when you use your abilities to interpret what the machine gives, not just generate the report from the instrument and share it with your consultant who has sent the patient or the sample. You become a consultant when you add value to the report that the machine generates. Remember this, never ever forget this, that we all trained first to become physicians, we all trained to become doctors. We chose to become experts in the laboratory, in laboratory medicine, in whichever part we have chosen. When a patient has a problem, he reaches a clinical consultant. When a clinical consultant has a problem, whom does he turn to? So you are his consultant. So do not underplay your ability. Do not underutilize your ability. Keep sharpening your acumen by constantly interacting with the clinical consultant, and remain always a consultant to the consultant. Never give up that very, very precious spot, because you and I are the ones who can give proper direction to a patient's management. If we miss something or if we misdiagnose something, the train will derail. It is in our hands to play Watson to Holmes. Holmes is great because there was a Watson. And Holmes has acknowledged that. By Holmes, I'm meaning Sherlock Holmes. Anybody here who has not read Sherlock Holmes? Not read Sherlock Holmes? Sherlock Holmes is the reason why I did pathology. So I think we should be, because Watson asked the correct questions, Holmes looked at in the right direction for clues. Okay? So wish you all good Dr. Watsons, and enjoy your work always.